Thank you. Fred, would you mind introducing yourself, please?
Bushu ni jani shinabi do kwewag wasamoganini indigo makwandu demo ga kaning and doing jaba jaganashi muda. So Fred Dejarli is my name, and I work at NACC as the elder in residence, spiritual care. I was born and raised in Red Lake. Lightning Man's my name in Ojibwe, and I'm from the Bear Clan. So Miigwech.
And I'm going to just introduce the rest of the ECHO team. Michelle, would you introduce yourself?
Sure thing. Hi, I'm Michelle Corcoran. I'm the nurse manager for the MAT program at NACC. Thanks for joining us.
Nikki?
Hi, I'm Nikki Giardina. I am the infectious disease nurse at NACC.
Which Tina?
My name is Tina. I'm the harm reduction supervisor at NACC.
And I'm Kari Rabi. I'm a family practice and addiction medicine physician here at NACC. Thank you. We'll just go ahead and start the slides. So welcome everybody. We've to our ECHO today. We're going to have Nikki talking to us about safer drug use today. As far as our agenda, thank you, Fred, for the prayer and land acknowledgement. I'm doing the introductions and agenda. I'll go through Zoom guidelines really quickly. Tina will give us some information about other ECHOs and other announcements. We're happy to have Nikki doing our didactic today. And then if we have time, we'll have a case presentation, and then Tina will close. So as far as Zoom goes, please let us know who you are. Introduce yourself in the chat function. Actually, Tina, are we still doing this with the intro slide that people have to come through? No, so you don't need to do that because we are collecting your information as you come in, and thank you for doing that. And then as we have said before, you can update your name on your screen just by right-clicking and updating, and then people can see who you are. Next slide. And then if you could please turn your camera on so we can see you. It's just so much easier to have a conversation when we can see everybody who's on with us, and we really appreciate seeing you. We know that people have to have lunch and everything. We don't mind if you're eating. If you are not speaking, please mute your microphone. If we do have noise coming from your square, we might mute you. Please don't take offense. You can use your chat or hand raise function for attention if you have a question, and please no protected health information on the ECHO. And I'm going to turn it over to Tina for announcements.
So our next ECHO is on July 6th, and it's going to be a repeat with Mo Mike from Indigenous Peoples Task Force, talking about harm reduction. And the presentation is titled "Harm Reduction is Traditional." There are other ECHOs on a lot of different topics, and a lot of ECHOs on specifically opioid use disorder and harm reduction. So if you want information about where to find those, please just let me know and I can send information your way. So Stratus Health, who is our partner in this project, they have a new site called CORE, Center for Opioid Resources and Education. It's just a hub where you can find all sorts of different kinds of resources related to OUD and MOUD. So I can also send you that link if you're interested, and just use the chat to let me know if you need any of these things from me. Stratus is also facilitating a medications for opioid use disorder treatment bootcamp. It's going to be Friday, June 17th in Grand Forks, North Dakota. So if you want information about that, I can also connect you with Stratus and help you get registered for that. And finally, our ECHO is looking for some assistance from our audience members. We are trying to launch an effort to just get a better idea of the topics that our communities want to hear more about, and get a better idea of who the experts are out there who want to share case presentations, and also share any presentations that they have on the topics of OUD and harm reduction, clinical topics, and also outreach and support staff related topics, and behavioral health, stuff like that. So this is going to take place in the form of a survey that we are in the process of creating. We're almost done. And then also in the form of upcoming listening sessions that we hope to schedule with individuals and teams across Minnesota and even across the Midwest. So please let me know in the chat, or if you have my email address, you can just send me a quick email. Let me know if you want this survey, or if you want to do a listening session, and we can get all that set up. So thank you all for being here, and if you are interested, we just really appreciate your participation in this. So those are my announcements. Oh wait, I'm not done. Sorry. Case presentations. I think most people know the drill on this. They're a time and space for us to bring real life scenarios to the group, for us to talk about them. If you would like to bring a case presentation to this ECHO, please let me know. And then continuing education credits are available to eligible providers. And if you are interested in a case in getting continuing education credits, you'll just have to complete the survey that I send out after this session. So yeah, now I'm done. I'm going to stop sharing and I will hand it over to Nikki.
Okay, thanks, Tina. Let me just go ahead and share my screen. Okay, does that look great to everyone? Okay, wonderful. Thanks. So my name is Nikki Jardina, and I am a nurse, and I work at Native American Community Clinic, and I do I provide care coordination for our HIV and hepatitis C programs, and more broadly, just around infectious disease. And so my work overlaps a lot with our harm reduction work, so involving working with people who use substances in order to provide education and supplies and referrals to support people in being able to reduce potential harm to themselves or others related to drug use, however that looks for the individual. And so I've been working in harm reduction for a lot longer than I've been a nurse. And so I, when I became a nurse, was really excited about the overlap between the two. And so I think a lot of what's in this presentation sort of reflects that. Yeah, I think that looking at harm reduction in more clinical ways is a really powerful tool to offer to people who use drugs, to give them access to information to take the best care of themselves that they can. So if anyone has questions, feel free to interrupt me. Or if anyone has like, oh, I wonder, am I gonna have to let people in, Tina? Oh no, okay, you'll still see that, okay.
Yeah,
all right, let's see, oops, if I can progress the slides. Okay, so why is this important? Oh, and I'll also just say that I'm going to talk really frankly about drug use and a little bit about sex as well. And so if anybody doesn't feel like hearing that today or anything like that, please feel free to hop off. And I use she, her pronouns. I can't remember if I said that already. So why is this important? I already basically said this, but harm reduction philosophy says that people who use drugs deserve access to information, just as people who do anything that impacts their body and their health deserve access to information in order to reduce harms and stay the healthiest they possibly can. So, a lot of our sort of culture around drugs in this country has resulted in, for a long time, a real lack of information, and so people, when they don't have access to information, are more likely to do things that are less safe or become dependent on people who maybe don't have their best interest at heart. And so our kind of guide here is that, information equals power. another important thing I think is that there've been a lot of studies on harm reduction, so distribution of syringes and other supplies and education. And those studies have shown that harm reduction interventions don't lead to increased drug use. So offering information about using drugs, it has really profound effects in terms of improving people's health, reducing rates of infectious disease and other kinds of infections, reducing overdose death, and actually connecting people to higher levels of care like treatment, and it does not increase drug use. And yeah, harm reduction also just says that, you know, abstinence shouldn't be the only answer, that not everybody is ready to stop using drugs. And so people who are using drugs, you know, deserve care as well. So just to go over a little bit of what the general harms and risks associated with drug use are. So infectious diseases like hepatitis C and HIV primarily, infections of the skin largely related to injecting drugs, damage to blood vessels, blood loss, nerve damage, and then infections associated with organs, so like endocarditis, so an infection of the heart, osteomyelitis, an infection of the bone, sepsis when an infection spreads to the bloodstream, overdose, of course, and then there's also the social risks associated with drug use, so involvement in the criminal justice system and ways in which drug use can affect interpersonal relationships as well. So when we talk about safer drug use, we often think about things sort of in this hierarchy of risk model, meaning, oh, I'm seeing somebody's trying to get, you guys are probably all seeing that too, that someone's trying to get onto the Teams echo, Tina.
Yeah, I'm like texting people and emailing.
Okay. So there's sort of the most ideal way to do something, the way that carries the least risk, and then you can sort of think about the spectrum all the way to the least safe or the most risky. And so we'll talk about that a little bit, but rarely is it really this simple. But the reason that we talk about the spectrum of the hierarchy of risk is because that's sort of what harm reduction does. It recognizes the reality that not everybody is going to do the safest thing all the time. And so how can we give people choices to make any positive change, even if they're not necessarily going to the least risky option in the spectrum. And so this is an example of the hierarchy of the hierarchy of risk. So, you know, in terms of injection drugs, so never injecting would be the safest. And then all the way at the harmful end would be sharing equipment with other people, you know, obviously leading to a great increased risk of HIV and Hep C transmission. And then there's a couple options in the middle, like if you're going to inject using a new sterile syringe every time and never sharing, or if you are not able to use a new sterile syringe each time to clean your equipment and not share it. So there are always some options in the middle. But again, like I said, it's not always this simple. So here we have kind of all of the different ways that people use drugs, all the different routes of administration. And I sort of tried to put them in a hierarchy of risk order, but again, I don't think it's always exactly this simple. But we're going to talk, I would say, like 70% about injection and then a little bit about other modes of administration. All right. So injection, so that's when people use syringes to inject drugs directly under the skin somehow. And so probably the most common way that people use drugs intravenous through an injection is intravenously, so directly into the bloodstream. But then people also may inject drugs into their muscle. So that's like the same way that when you're given most vaccines, it's just put right into a large muscle. And then intradermally, or sometimes people call this skin popping, but I don't know if you're going to come into contact with people doing intradermal injections that often, but we'll talk a little bit about that. Oops. Oh, my slides are fancier than I remember. So in terms of intravenous drug use, so obviously, you know, it's relatively high risk, but we see it so often. And so I think it can be helpful to think about, why are people injecting drugs intravenously? You know, what are the benefits? And so, you know, it's really efficient because you're not losing any of the drug to the air. Like when you're smoking, it's really, you know, being entirely put into your bloodstream. So your body is able to get the maximum effect from the least amount, you know, economical again. And the effects come on quickly and intensely and may last longer. And people are often seeking out that rush, that sudden effect from the administration. Risks, you know, because the drugs are impacting the person in a more concentrated way, there's a higher risk of overdose. There's also a higher risk of infectious disease. Anytime anything is being put directly into someone's bloodstream, infectious disease risk increases. And then wounds, so any kind of infection happening around the area where the injection occurred, and we'll talk about that a little bit more. And then also, of course, then having to carry equipment such as syringes and other IV drug use equipment that can sometimes be against the law depending on where you live. And so that's another risk. So in terms of finding a spot to inject, so this is another use of the hierarchy of safety model. And so arms are going to be the safest, then hands, then feet and ankles, then legs, then the groin, and then the neck, breast, and penis areas in terms of risk. A lot of I didn't create any of these images, so most of them are from CATIE, C-A-T-I-E, which is an organization in Canada that does HIV and hepatitis C education, and they're really wonderful. You should check out their website. And so I think there should be links to all of the images at the bottom of the slide. So this is just an example of areas that are safer versus less safe for people to try to access veins in when they're injecting. And so some suggestions we like to give people: always inject towards the heart, so, you know, in the direction of blood flow. Rotate sites, so sometimes people will find a spot that really works and inject there over and over again, which increases the risk of actually losing access to that vein. So we recommend that people try to rotate amongst a variety of different sites, but, you know, trying to remain in those safer areas. Inject downstream from a recently used vein. So, or, you know, if somebody has some kind of infection, if they have an abscess or cellulitis, to inject downstream from that, so that we're not kind of getting that flow through that spot that could potentially result in spreading an infection to the bloodstream, or dislodging a clot from like a recently used spot and sending that into the bloodstream. We recommend, if people are injecting into the small veins in their hands or feet, to inject really slowly. Those veins, you know, can't handle as much fluid as the larger ones in the arm can. We recommend people take off rings before injecting, so that if they're swelling or they get an infection, they're not then stuck with the ring on a swollen finger. And then just to be aware of the risks of injecting in legs and feet, that, you know, if it that there is the greater risk for infections and serious clots, but that also if there is some damage done there, and there's, you know, a problem with the function of the leg, that may sort of affect someone's life more than a temporary problem with something that's happened to their arm. So, and especially for people who are living outside, who are unsheltered, having limited mobility might be a really big problem for them. So just kind of thinking about like the reality of people's lives. And also in terms of injecting in feet, you know, if somebody doesn't have really great access to like a shower or clean socks, then we do worry about the introduction of a lot of pathogens into that area too. So the groin, the neck, the breast, and the penis are all very high risk injection sites. You know, if there's another spot to inject in, it's always going to be preferable. You know, I think that people, you can find some pretty interesting information out there about how to more safely inject into the groin. And then I would say that in terms of neck, it's kind of like a no-go. I mean, in terms of giving sort of clinical guidance, that's really, and again, feel free to interrupt me if you have a different perspective, but that it's just such a high risk of hitting an artery and such a high risk in terms of an infection in that area. There's just so many critical organs, you know, obviously near the neck, in the head. And so we really don't want to introduce pathogens into that area. Yeah. And so again, injecting into the groin is also not a good idea, but harm reduction wise, there is information out there on how to do it a little more safely. Idea being that if people are going to inject into the groin either way, might as well give them the best clinical information that we can give them. It's important for people to avoid trying to inject into arteries. And sometimes when people are trying to inject and they don't have any veins close to the surface and they'll kind of be digging around, it can increase the likelihood that you're going to hit an artery. And so, you know, some things to let people know is that it's not going to actually work for you. Shooting into an artery doesn't actually result in you getting the effects of the substances. Like I mean, you may just lose the shot entirely with the power of the blood coming out of the artery, but then also, you know, it'll just get pushed kind of into the tissues then. Like it's not gonna reach your brain efficiently. And so people can actually see visually that they've hit an artery. There'll be pain, there may be blood, sort of frothy, bright red blood pulsing into the syringe. And so our recommendations are, if you do think you've hit an artery, to stop injecting right away, pull out the needle, put pressure on the wound, try to elevate it and get medical help. So we'd consider that to be a medical emergency if you think you've actually gotten access to an artery. So, you know, and this is one of the reasons we always recommend that people inject sort of slowly, so that if something is awry, they'll notice it before they've done the entire injection. Oops. Taking time and space. So I think a lot of safer injection tips are related to being able to find a place and a time and a situation in which the person injecting has access to some things that just make it safer. So those things are kind of like, you know, a good headspace if possible, not feeling extremely pressured or distressed, light so that they can see, running water, you know, someone else around to respond in case there's an overdose or another emergency. And these things aren't always possible, but however many of them that we can get in any individual situation, the better. And of course, this is why people are often using restrooms to inject, because it's sort of a unique public space that offers a lot of these things. And so yeah, they're very desirable then in that case. In terms of, you know, reducing the risk of missing a shot or accidentally injecting into an artery, I mean, giving people tips on making their veins as available and obvious to them as possible can be helpful. So recommending people stay well hydrated, using some kind of like warm compress or running warm water over the area that they're going to inject in can help bring some veins closer to the surface. A little bit of exercise, having the area below the heart so that there's more blood pooled there can make veins easier to find. We recommend people do not inject into areas where they're feeling a pulse coming from, because that's a sign that there's going to be an artery there. Cleaning hands and site. So cleaning the site that you're going to inject into and your hands can be a great way to reduce the risk of infection. And then, in terms of, I think I just mentioned the idea of being in a good headspace. So sometimes when people are in withdrawal and they're going to inject, they feel a lot of desperation. And so that desperation can lead to rushing or other things that can result in potentially injecting in a riskier way. And so sometimes, people may opt to do a little bit of their substance in a different way than injecting. So to sniff or smoke a little bit of their substance to calm down enough that they can inject more safely. I'm sure everyone's seen this image before. It's everywhere. And so, but basically just to remind folks that using a syringe over and over again results in the syringe becoming more and more creating basically larger wounds every time you inject. And so, and of course it picks up pathogens every time you're injecting. And so then if you're reusing that syringe, you're introducing more and more pathogens into that wound, that larger and larger wound. And so then just, greatly increasing the risk of damage to the tissues and infection. And so people, when they're choosing syringes, they're deciding, do they want, a 27 gauge or a 30 gauge, for example. And so the 30 gauge is going to be really skinny and the 27 gauge is going to be thicker. And so when the 30 gauge, that really, really thin syringe needle, is going to create a smaller hole when you inject with it. And so in some ways that's good because that means that the wound being created by the injection is smaller, but it will blunt faster. So there are fewer times that someone can use that one single syringe with a 30 gauge than they can with a larger syringe with a 28 gauge or a 27 gauge. So again, that's that's why I say that hierarchy of risk idea is not perfect, because sometimes there are benefits and drawbacks to making certain decisions. All right, so here is just a general idea of equipment that people use to inject. So the syringe obviously is the tool that administers the drug, and then cottons, which people use so once they've dissolved their drug in water in the cooker, so that little tin, they then will put the cotton into the drug and use that as a filter through which they draw up the drug, the dissolved drug, into the syringe. Tourniquets, same thing that they use in a lab when they're drawing your blood to make veins more accessible. Alcohol wipes to clean the area that they're going to inject into. And in a pinch, if there's no running water, they can also be used for someone to clean their hands or to clean their equipment. And matches or a lighter to create heat to dissolve the drug in water inside the cooker. So just some general safer injection tips. Like we said, wash hands, wash the cooker if it's been used before, cover the surface. With hepatitis C, we see it's just so easy to transmit, and even if it's just on sort of surfaces that you're touching while you're preparing your shot. So even just taking some newspaper or a shirt or something like that and putting it over the table or ground on where someone's preparing their shot. Completely dissolving the drug is important because we don't want to inject any large pieces of the drug. We want it, as broken down as possible. Filter with clean cotton. So try not to use things like cigarette filters or cottons that other people have used. I think one element of teaching people safer injection is that it can help them if they are in a relationship that might be abusive or controlling. It's pretty common to see dynamics of couples where one person, they're both using injection drugs, but one person injects them both. And so then that person who's being injected, the other person then has some power and control over the person who's not injecting themselves. Because without that person who's injecting them, they're going to be in withdrawal. They're not going to be able to dose themselves. And so learning how to inject oneself can be pretty empowering in that way and allow somebody, to make more of their own decisions overall then. We remind people to inject with the bevel up. So the syringe then has it, it doesn't end at a flat point. There's a diagonal. So make sure that's pointing up, generally at about a 45-degree angle to the skin. Remember to untie the tourniquet before injecting. And then we remind people to check for blood. So meaning to pull back on the syringe to make sure that some blood enters into the barrel before injecting, to make sure that you're actually in a vein. This is obviously impossible to see on your computer screens, but this is just a really cool poster that has, again, that hierarchy of risk from the green down to the red of different types of water that people use to inject, to dissolve their drugs into before they inject them. And so an unopened, sterile container of water, medical grade, is going to be the safest, but people don't often have access to that. And so kind of going down the list, cold tap water is pretty good, actually. And so, so I think that's a really sort of realistic, relatively safe option for a lot of people. We recommend cold water, not tap water. Not hot water, because that carries more pathogens. And, then people sometimes become really desperate and don't have any kind of water on them. And so they wind up using water from a toilet, for example. And so then in that case, we'll tell people, all water from a toilet can carry some pretty serious risks. But if you are going to use water from a toilet, use the tank instead of the bowl, because the tank water is going to have less bacteria in it. So, or if you're outside and have absolutely no access to water, other than water that's literally on the ground, that using water that's moving is going to be a little bit safer than using water that's stagnant. But of course, we really try to encourage people to find other options for water. Okay, hepatitis C. So it's very easy to treat drug use. Obviously, blood content. Intravenous drug use is the most common transmission mode. The actual virus is very small, so it enters the body more easily than something like HIV. It also lives outside the body much more easily than HIV. It's air. I'm being told my internet is unstable. I hope we're okay. Can you still hear me?
You're cutting out a little bit here and there, but it seems like you come back pretty quickly.
Mm-hmm. Can you hear me now?
My connection is unstable as well.
Can you guys maybe turn off your cameras and see if that helps?
Sure.
All right, looks like we're having some technical difficulties. Hang in there, everybody. We'll figure it out.
Did we lose Nikki?
We did lose Nikki. Dr. Robbie, are you near her?
I can go find her.
My internet, I got an alert as well saying that my internet was unstable.
We're okay over on this side of the clinic.
Okay.
Can you hear me now?
Hi, Nikki. Yep.
Hi, are you able to hear me?
Yeah.
Okay. Sorry, unstable internet connection. I'm like right in the clinic, so I don't know what happened there. And then I had to like redo that login thing. So sorry about that. All right, let me get back on the PowerPoint.
I may need to make you co-host.
Oh yeah.
There we go. Okay.
All right. Okay. So I don't know how early I cut out, but I was just talking about hepatitis C and how it's really easy to transmit via IV drug use because it lives outside the body for a lot longer than HIV, for example, and the virus itself is much smaller, so it enters the body more easily. We're going to be especially concerned about the risk of hepatitis C for people who also drink alcohol or people who are also infected with HIV. And one important thing is that all injection equipment can carry and transmit hepatitis C, not just the needle. And so when we're teaching people about how to reduce their risk of hepatitis C, or, for anybody here who like works in healthcare, we're kind of teaching like a clean technique. I don't know that this necessarily like occurs to people automatically if they're not like an MA or nurse or something like that. And so that, if there is something that is going to come into contact with the drug that you literally put inside your body, don't touch that with your fingers, keep it clean, and to, not licking the tip of the syringe, for example, that we're almost teaching a little bit of like an amended sterile technique. Like once something's clean, don't touch it again. So we encourage people to label their equipment if they're injecting with other people so that they know which equipment is theirs and which equipment is other people's. Try to avoid sharing straws and pipes for if people are snorting or smoking drugs as well, because that can also spread hepatitis C. And that if sometimes people will cook up a shot and then share it amongst several people. And so we also encourage people to use a brand new needle to backload their own syringes so that they're not accidentally coming into contact with anybody else's used syringe. So this is a nice little image here. These are different ways that people can label their own syringes so that they don't accidentally use other people's syringes if they're injecting with other people. I like the scraping off a number on the barrel idea. Bleach. So people talk about bleaching their syringes, and it's not a super effective, or it's not as good as making sure you're not sharing syringes or using new syringes every time. But does it have some effect on HIV in the syringe? Yes. It is not going to kill the hepatitis C for sure. So, I think it probably has some positive effect on that too, of course, just rinsing out the syringe would. But this is not a technique that we're really promoting, but we think it's important to know about it, especially if people ask. This is like a good sort of basic guide on how to bleach syringes. Basically, you're rinsing out the syringe with water, and then you're kind of soaking the inside of the syringe in undiluted bleach for 30 seconds, and you want to try to get bleach on the outside of the syringe too, and then rinsing it with water again. But again, we're not really promoting that as a clinic. It's not considered like a super effective tool of infection prevention. So we're going to kind of move away now from injection drug use. This is just a nice chart, I think, that shows a bunch of different ways that people use drugs and their relative risk. And we'll talk about, some of these in more detail in just a minute. So inhalation smoking, probably like, the second most common way that people use drugs. Why do they do it? It's really easy. You don't need that many special tools. Rapid onset, the onset is faster than through injections. So There are risks, infectious disease, primarily Hep C, with sharing smoking equipment with other people, inhalation or ingestion injuries, sores and burns in the mouth and throat. There can also be damage done to like your teeth and gums, and then overdose. People can overdose from inhalation, even though generally it's a lower risk than through intravenous use, but it's still there. So crack cocaine and meth are often what people used, what people smoke, but people smoke heroin or fentanyl as well. For crack, generally people are going to be using like a stem, just a straight stem. We encourage people to have their own mouthpieces so that you don't have multiple people's lips on the same pipe, because that pipe can get very hot. And if people's lips are cracked, then blood can be transmitted from one person to another, which is definitely a Hep C risk. I suppose probably a small risk of HIV as well, but we mostly think about Hep C when it comes to that. So some of the tools that people are using when they're smoking out of a straight stem like this, they're going to use these little screens, and we encourage people to use a few of them, it's sort of acting as a filter, and to push it down with some kind of wood stick, and then apply their mouthpiece, and then they apply the heat to the other end, and then inhale the smoke. So some of the tips that we use to reduce risks this way are, again, to clean your hands, clean your mouthpiece, inhale slowly, and we discourage people from actually holding what they've inhaled. It doesn't actually increase the high to hold it for longer and can do more damage to the lungs. We also encourage people to avoid touching the end of the stem because it can be very hot. So rubber mouthpieces can be really nice. People will use like spark plug covers or rubber bands. We encourage people to get rid of broken pipes or mouthpieces because they're dangerous. They can cut your lips. And if you need to share a mouthpiece, to clean it with bleach or alcohol wipes and Vaseline on the lips. The more sort of moist and supple the mouth and the inside of the mouth are, the less risk of transmission of infectious diseases. And Vaseline is like a really great barrier. So we also talk to people about trying to avoid using things as pipes that are not meant to get hot. So things that are like plastic or very, very thin. We just run the risk of things breaking while we're using them, or of things giving off fumes. So just like a rubber mouthpiece and a glass pipe are kind of ideal. I'm not going to go into this in great detail, but you definitely have access to this in the PowerPoint. This is just a nice guide on how to get the filters, the screens into the end of the pipe, and they're calling it gauze here, I think, because I think this is maybe
I don't know if it's true for everybody, but I'm not seeing you advance your slides.
Oh, like which slide do you see?
I see HIV outbreak.
You see HIV outbreak?
Yeah. Is that what everybody else is seeing?
That's what I see.
Yeah.
Oh, that's not what I have up on my shoot.
Try and reshare your screen, Nikki. That might help.
Oh, all right. Are you seeing it now?
Yeah.
Yes. Now we can see it. Sorry about that. I was wondering a little earlier, but
Well, so this is whatever. I don't know. Was that whole time you were seeing that?
I'm afraid so.
Oh, someone should
Sorry,
have told
everyone.
me. Okay. This is the routes of entry slide. We'll go through them quickly. These are images of different supplies that people use to smoke crack. Sorry about that. This is just a guide for how to set up the crack pipe. And then this is the guide for getting the screens into the end of the crack pipe. And we recommend that people use screens that don't have additives to them. Like sometimes people will use steel wool, but sometimes it can have like soap or cleaning substances in it, and inhaling that can be very caustic, for example. With meth, often people will use a pipe that has a bubble or a sphere at the end, but and so they're not gonna be using screens in this, but you know, it's still pretty sort of similar concepts in terms of having your own mouthpiece, keeping your lips as moist and barriered as possible, cleaning your hands ahead of time, not using broken material, not holding the hot smoke into your lungs for longer than possible. One thing about meth is that it can be very damaging to soft tissues. It causes vasoconstriction and has an antihistamine effect, meaning basically that it makes your body, everything your body secretes, it'll inhibit that. And so mucous membranes can become very dry and vulnerable. For example, you can't inject, well, if you inject meth into your muscle, for example, that can be very damaging to the muscle. And so, so meth itself is just really caustic. And so, you know, again, try to stay hydrated, use lip balm, practice dental care. And then, you know, sometimes there'll be a combination of meth, and I shouldn't just say anal sex here, and any kind of sex. And so just to keep in mind that those mucous membranes may be really dry and vulnerable. So and that can lead to an increased risk of sexually transmitted infections. And so we try to encourage people to, you know, use some kind of barrier method with sex, and try to use a lot of lube. That can help as well. And lube on its own is more effective than no lube, even if people are not using condoms. So wounds, just really briefly, of course, are a tool that are a harm that comes from drug use. And so just teaching people some basic self-assessment so that they can determine, you know, is this something I can keep watching at home, or do I need to go into the emergency room or go see my doctor? You know, signs of a wound would be like symptoms of sepsis, like feeling generally very sick and fluey, or red streaks coming away from the wound, something growing, turning colors like green or black, if there's an odor coming from it. And then just like basic wound care tips, you know, keeping it clean, moist, and covered. And then overdose, of course, is a major risk associated with substance use. And so just getting trained in administering naloxone and carrying it is a really good tip. Also just encouraging people to think about how to reduce their own risk of overdose at any given point, regardless of the presence of naloxone. So just knowing that after a period of sobriety, someone maybe not have as high of a tolerance as they did when they were using steadily. So coming out of being incarcerated or rehab, they may want to start with a much smaller amount of drug than they would have used before. Using a tester shot, so doing a very small amount of a drug, if it's from like a new supplier, something like that, just to see what the effects are before one does more of the substance, trying to use with others, mixing, especially 2 different downers, and then PrEP, pre-exposure prophylaxis. So this is taking, it's actually taking medication that's used for people with HIV, but taking it when you do not have HIV in order to vastly decrease the risk of contracting HIV. And so PrEP is available for people whose main risk is IV drug use. And then of course, people have risks that are both sexual and IV drug use. And so getting, you know, more providers to offer low barrier access to PrEP is a great way to reduce those risks. And then just getting the message out. I think we're gonna be almost done here. But yeah, just sort of some general like harm reduction suggestions, including info with supplies so that people are kind of getting that education as they're getting the supplies they need, keeping things readable, using language that's actually used amongst people who are using substances, and then, you know, having people who use drugs as involved in the creation and delivery of harm reduction messaging is kind of core. And then obviously we all know addressing these co-occurring factors that contribute to drug use risks. So housing first, treating pain, behavioral health care, and then, you know, just understanding the role of inequities, of injustice, of historical trauma in drug use and in relative risk, and really going from what the client's priorities are. And there is my resource list, and so feel free to use this and go through and really explore. There's a lot of really interesting material out there on this. So, oh, and I guess that's you, Tina. That's all I have. Thank you.
Hey, thank you, Nikki. That was comprehensive. I really appreciate it. Anybody have any questions for Nikki around safer use?
Looks like Gia.
Hey everyone, I was just like doing the applause for you.
Yeah, as I see it's clapping. I didn't notice that was there. Like it.
I have a question, it's Marissa. So you mentioned using the language that they use. Sorry. Okay. So what if you don't know that language? What do you like, I don't know the lingo or.
Totally. That's such a good question. I think what I'll say, but then I'll also welcome like anybody else, Tina or James or anyone to pipe into. I think being honest about not knowing the language is like totally fine. And I also often don't know words. And so, I think people appreciate when also we as providers treat them as the experts in what they're doing. And so saying like, oh, I'm sorry, I don't know what that word means. Like, do you mind teaching me? Just sort of making it like a, putting them in the position of power and of educator in the situation. Yeah, and so yeah, again, I think just asking and being direct and being non-judgmental is probably the best thing to do in the case of not knowing knowledge. And then in terms of like using that language, I think that's sort of more for harm reduction programs, and hence why we really want to make sure that harm reduction programs are staffed by people who are substance users or have experience with it, so that that language is used. But like in the case of not working in harm reduction all the time, I think asking and being honest. Does anyone else have any sort of tips for that? It happens to me a lot. So
I think once you do know, also you can just sort of mirror their language a little bit. So just listen to how they're talking about it and then try to mirror that. And as Nikki said, of course, ask if you don't know, don't just mirror if you don't know what you're talking about. But once you do know what the word means, and if they're using a particular word for it, then you also use that word.
and maybe a little bit of like humor and self-deprecation at times is fine, to say like, oh my God, I'm really out of the loop. Sorry, what does that mean? Something like that, just so like it's like the onus is on the provider to be the one who's being self-deprecating, as opposed to the patient being like accused of having, saying things that are weird, or like, what does that mean? That kind of thing. So, oh, is Dustin, are you saying no? Okay, I don't know what you're saying no to.
I was making a joke.
Oh, okay.
Yes, the humor is a great thing to do.
Okay, any questions before we wrap up? We're almost at 1 o'clock. Okay, well, thank you so much for joining us. Tina, can you remind us what our next echo is?
The next echo is July 6th with Mo Mike from IPTF. Harm reduction is traditional.
Thank you. Miigwech, everybody, for joining. We'll see you in a couple of weeks.